Hello, and welcome to this IPEM roundtable discussion, which we've entitled What the Health and Social Care White Paper Means for IPEM Members and the Professions. I'm Robert Parley, the President-elect of IPEM, and today we're going to be looking at what the white paper might mean for physicists, clinical and biomedical engineers and technologists in broader terms, with issues such as workforce planning, patient voice, resources, funding, timing and statutory registration all considered as part of our discussion today. This discussion will be turned into an article for Scope magazine and also a podcast, and indeed it's the first of a series that the team of IPEM are hoping to produce on issues that matter to you. So please do get involved as an audience. We would like to ask you to comment and share the podcast across your professional and social networks, and all comments will be picked up by our communications team and will be added to our wider understanding of the issues surrounding our professions today. I'm going to introduce the panel members in a minute, but first of all, a little bit about me. As I said, I'm currently the President-elect of IPEM, and I'm chairing this discussion today. I'm the head of medical physics and clinical engineering at Leeds Teaching Hospitals, although I didn't start my professional career as a physicist, but rather as a chemist, and spent many years in academic research, particularly in the field of electron magnetic resonance. I've evolved an interest in education and moved into the NHS in 2003, where I trained as a radiotherapy physicist and have worked in a number of organisations from the small to the very large. I've been involved in the Level 7 Clinical Scientist Apprenticeship scheme and have had a number of roles in IPEM, being a former director of the Professional Standards Council, and I'm currently chair of the Prizes and Awards Committee and the LGBTQ Network Mentor. So I'd like now to introduce our first panellist, Angela Douglas.
Thank you, Robert. I'm Angela Douglas. I'm the Deputy Chief Scientific Officer for NHS England and NHS Improvement. In the Office of the CSO, obviously our healthcare scientists are really important to us. Medical physics and clinical engineers are one pillar of that healthcare science workforce that we lead. Recently, I've had the pleasure of chairing the Clinical Engineers Forum. This started last year and has built into a community of practice that has really made an impact during this COVID period. So I'm really pleased to be part of this panel.
Thank you, Angela. And our next guest is Anna Barnes.
Thank you so much for inviting me to be part of this panel. Let me introduce myself a little bit. So I am a clinical scientist by training, and I've been registered since the late 1990s. I also have a PhD in neuroimaging, and I have done postdocs in academia in America and as well as the UK. I have also worked in industry with GE Healthcare in their Amersham headquarters, developing radioligands for neuroimaging applications. Most recently, I spent a year as representative for IPEM on the National Imaging Optimization Delivery Board, which went into crisis management during the pandemic to make sure that all imaging services were kept up and running and all departments had the equipment that they needed. And leading on from that, I recently took up a post with the Chief Scientist Office as Regional Healthcare Scientist for the South East region, NHS England, and I have the pleasure of working alongside Angela Douglas.
Okay, thank you, Anna. And next we have Robin Mcdade.
Thanks, Rob. I'm an advanced specialist clinical technologist working in the field of nuclear cardiology in the Glasgow Royal Infirmary. It's a very clinical, patient-facing role. My professional interests, I've got a broad background in clinical physics and imaging, teaching healthcare science, resuscitation and ECG reporting, and I sit on IPEM's Professional Standards Council as their current lead for the Technologists training scheme.
Thank you, Robin. And finally, we have Nick Gulliver.
Hi, Rob. It's a pleasure to be here today. My name is Nick Gulliver. I'm the Chief Clinical Technologist and the Service Manager in the Nuclear Medicine and PET CT Department at King's College Hospital. I've worked in nuclear medicine both as a clinical technologist and as a clinical scientist since early noughties, late 90s, shall we say. My interests are in both the clinical side and the management side of nuclear medicine, with a focus on workforce planning. And I am the former chair of the British Nuclear Medicine Society's Technologists group, and I'm involved in the IPEM training scheme as a moderator.
So over to our first topic now, which is going to consider the white paper in the whole. The white paper has some far-reaching changes in it, affecting regulation and integration and funding. And I was wondering how the white paper proposals will affect IPEM members, including medical physicists, clinical engineers, and technologists. And first of all, we're going to go to the non-IPEM member here for perhaps a broader view. Angela.
We created a National Clinical Engineers Forum last year that's become a community of practice. This group have been real solution driven, and they've worked as an integrated system of regional engineers. All the innovative practices that they've adopted have been recognised in this paper, and the proposal captures the initial learning from the experiences of the health and care systems in responding to the pandemic, and is attempting to make them permanent. Now, some of those innovations are beneficial changes that we want to see accelerated as part of our new and better ways of working. And the paper provides a framework which actually allows us that further evolution and support to harness and sustain all of that collaboration, the integration of working, and all that practice and innovation that we've seen during this COVID-19 pandemic. So I actually think the white paper will benefit our medical physicists and in particular our clinical engineers, because it recognises the way they've been working over the last year and will help to embed that into good practice going forward.
Thank you, Angela. And I'd like to pick up on a couple of points you mentioned there. The first is about the recognition that's happened over the past year with the work, particularly of the medical physicists and clinical engineers through the pandemic, and integration. And one of the challenges that have been for physics and engineering and healthcare science as a whole, particularly with the ICS structure, has been getting our voices heard. Do you feel that with the mandation of the ICSs, as outlined in this paper, it's going to be more challenging for us as a profession to have our voices heard? Or do you think there are strong mechanisms for us to have a say in what happens at the local level and the regional level?
So, Robert, Anna Barnes is one of our regional leads who's been working out in the system. And what we've charged all our regional leads with doing is setting up that system approach to leadership. So identifying their own network of leaders that are going to be working very closely with our integrated care systems. The white paper highlights how our clinical systems need to be led in a multi-professional way. And so we are holding our clinical systems to account to ensure that our healthcare scientists are involved in any transformation that's going to be led through those integrated care systems, because we believe that our healthcare scientists are really important to diagnostics, as we deliver 80% of the diagnostics across the NHS. And as diagnostics is going to be a key feature of our integrated care systems, the voices of our healthcare scientists really need to be heard.
Thank you. That's quite reassuring. I'm going to now move to Nick to see what views, perhaps from the clinical technologist workforce, and that Nick has.
Thanks, Rob. Well, I think reading the white paper, I think it's clear that there is a case for joining up and integrating care around people or patients rather than around institutional silos that sometimes the NHS has been guilty of working within. In addition to NHS and local authorities being given a duty of care to collaborate with each other, it obviously brings forward these measures for statutory integrated care systems. Now, of course, that will mean that the integrated care systems will have what might be called an imaging network for each of the ICSs, where as technologists on the, shall we say, the front line or the coalface, we may not immediately feel like we're part of a larger workforce, but there will be a duty for us to collaborate with perhaps neighbouring trusts in a single imaging network for the ICS. I think on safety and quality, as a topic within the white paper, they're also talking about bringing forward measures to enable them to improve the current regulatory landscape for healthcare professionals, which particularly for technologists, clinical technologists, is a bit of a hot potato at the moment, in that clinical technologists are not under statutory regulation, unlike clinical scientists.
Okay, thank you. And we'll be coming to the issue of statutory registration later on. Robin, what are your views on this, perhaps from a slightly outside perspective and also from being very heavily involved with IPEM as a whole?
I think that the white paper does touch on some of the issues that affect clinical technologists, particularly around role clarification as it affects public health and safety. It's a perennial problem that technologists aren't on a statutory register, and therefore that means there's a level of ambiguity about their role and their very frontline clinical role that has never really been settled. How do we keep patients safe via registers that are not statutory but are merely mandatory? And I think this paper begins to touch on that. It talks about bringing benefits to removing barriers, providing flexibility and clarity to roles while tackling bureaucracy and confusion. And that's certainly a confusion that's felt on the ground and at the coalface. If it delivers on some of those things for clinical technologists, that will be good for both the workforce and patients.
And what do you mean by confusion in that sense? In what areas do you feel there is the most confusion and lack of clarity?
Perhaps it would be easier just to give you a kind of concrete illustration from practice. So clinical technologists work in nuclear medicine, for example. You can go through the practitioner training program and work as a nuclear medicine practitioner, or you can become a radiographer and work as a nuclear medicine practitioner. Now, both of these fields, exactly the same job, exactly the same deliverables on the shop floor. However, when it comes to skill bases, so for example, if I moved from my current position to a different hospital, because I don't have statutory registration as a radiographer does, it would be a negotiation, a local negotiation as to what different levels of bureaucracy we need to put in place so I could actually practice. And it's not just me, this is felt across the entire UK. So there needs to be a bit more clarity and a bit more support for the roles of technologists.
Thank you, Robin. So clarity, so hopefully that's what we're going to get out of the new legislation. And finally, Anna, as perhaps someone, if I go back to the beginning to what Angela was saying, who has a role that perhaps is pivotal in this, how do you feel this is going to affect perhaps the clinical scientists and your role within it?
What I want to say, I guess, is to answer the simple question of how will the government's white paper affect the IPEM members. I think if I imagine our membership, I can imagine them looking at that title and going, "Oh, that's not for me. I'm just going to get on and carry on doing my job because I've always carried on doing my job for the last 20 years through all these different changes, and I just keep my head down and keep doing it." But what I have found working at the level that I am now is essentially that we are a completely untapped workforce when it comes to delivering this sort of change. And thanks to the efforts that Angela has done really over the last year and the things that she's very quickly brought together, like the Innovation Technology Evaluation Board, which was fantastic. Just being able to reach out to her colleagues, which included us, of course, and provide an accelerated pathway for people to put forward their innovative ideas and quickly push them through into practical use. She was able to demonstrate that our workforce, is fundamental to putting a lot of this technology into practice. So what I would say to our members is take another look, stop for a moment, think about the ways that you already do innovation in your day-to-day work, and your ways of integrating, because we work in multidisciplinary departments, as diagnostics and treatment often is, and think about how you might want to take those things you do locally and scale them up.
Yes, and that, I think if I can summarise that, what appears to have come from all the responses is that for perhaps the first time in a big way across the whole NHS, we have been recognised as a profession for bringing innovation, integration and new ideas. But we've got to ride that momentum, take those ideas forward, make sure that we're heard, and make sure that we're involved in the new world, both to share our learning that we've been doing for many years, but also to ensure that some of the challenges, particularly around where roles overlap and our workforce issues, get heard at the highest level. And I suppose to some extent, I'm going to call on perhaps Angela about this, that actually we have the support of the CSO's office and at the highest level within the NHS, and it's there if we need it, and that IPEM and its membership should be using that. Is that fair, Angela?
I absolutely agree. We now have a really strong leadership structure coming out of the office of the CSO, not just those of us who are actually part of that office, but also through our regional leads, and recognising that 2 of our regional leads are actually part of your membership, and that gives you a really strong voice.
So IPEM's mission is to improve health through physics and engineering and medicine. And ultimately, the white paper and the legislative framework that it describes is about the patients that appear every day in our hospitals and in our primary care. Do we feel, as people who've read this white paper and had a chance to think about it, that the patient's voice and choice is heard and present in that white paper? And I'm going to start with Robin, please.
I think my thoughts are, I'm not sure that they are. I'm particularly thinking about the concerns for safety that the paper addresses. I'd like to hear the patient's voice more in the paper via a commitment to consult on which professions actually require statutory registration. I was thinking that patients who go for surgery or they go for their cancer treatments, that anaesthetic machine, that LINAC, was made safe by a clinical technologist. Or we've heard about folks retasking anaesthetic machines to be ventilators and during peak COVID, and the folks who actually did the job were clinical technologists, none of whom are on a statutory register. And I think it would be important in the future going forward, if we are going to change the landscape of legislation for registration, to hear what patients think about that sort of thing.
That's very interesting. And what do you think the patient's view of statutory registration is? How you, as a patient, let's say, using the NHS, how relevant is it to the patient, statutory registration? How important do you feel it is to the patients themselves?
I think that patients don't really realise what statutory registration is and how important it is. I'll give you a simple example. So clinical technologists who as I've given you a few examples of the roles they fulfill, they could be using a CT, a nuclear medicine scanner, and delivering that scan to a patient, or they could be planning radiotherapy treatment. All of these jobs entail risk. They're currently on a voluntary register, so it's not mandatory for any of these practitioners delivering these very frontline, very hands-on procedures to be on that register. Some are on our professional standards accredited voluntary register, but there's a real mismatch in risk. Let me give you an example. So on the PSA's voluntary registers, we have the Association of Aromatherapists, the Association of Clay Therapists, and various counsellors. There's a real mismatch in risk between practicing play therapy, aromatherapy, and different versions of counselling than there is to planning someone's radiotherapy. I don't think that the public is largely aware of that issue. And I hope from some of the language in the white paper that we can begin to address that.
I agree with what Robin's just said, actually. I think the white paper doesn't give an awful lot of information about the patient's voice. It does talk about patient choice quite a lot, in terms of choosing where they will be treated. It talks about NHS bodies having are being required to protect and promote and facilitate patient choice with respect to their services. We already have the any qualified provider written into primary legislation. I think going back to Robin's point about the patients not really being aware of why statutory regulation of their care provider, individual care provider, their professional that they're with, is important. NHS employers can't enforce non-statutory registration as part of a job description or a role. It's not compulsory to join a voluntary register, obviously, but this sort of non-statutory registration doesn't afford, I think, sufficient protection to patients in a modern day healthcare environment when, as Robin's described, treatment planning, administering prescription-only medicines under supervisions, performing high-dose procedures, administering radioactive pharmaceuticals or external beam CT scans as part of hybrid imaging. Given this complexity of clinical competencies that were required, certainly in the nuclear medicine field, where both Robin and myself work, this kind of lack of statutory registration or regulation isn't sufficient to provide security to patients who otherwise wouldn't know what two people standing in front of them giving them their care, who is a radiographer and who is a technologist. To them, we are exactly the same person. But radiographers, in the same way as clinical scientists, being statutory, having statutory regulation means there is an additional scrutiny on their training, their continuing professional development. It behoves us as clinical technologists to invest in our CPD and make sure that we are giving patients the best care experience that they can have. But without the statutory regulation covering the profession, there is the opportunity for technologists who aren't as skilled to remain in the workforce and give suboptimal care to patients.
But Angela, do you feel the patient's voice is well heard in this? And are there any areas, perhaps other than the regulatory landscape, that perhaps the patient's voice could have thrown through more clearly?
So I want to take a slightly different perspective, as you've just introduced there, Robert. I actually think that, so from our experiences, we know that patients prefer to be guided by healthcare professionals that are well knowledgeable, that they want to attend services and are driven by high quality care. But I think that they want to be involved in decision making around those services and that high quality care. With the standing up of our integrated care systems, we know that those systems from the vanguards who have already been stood up, they are really powerful drivers of patient-centred approaches. And not only are they looking to provide that choice and greater control for patients to be involved in transforming services, they actually value the patients as decision makers. So under the new models that are being described in the paper, I believe that the NHS services as decision-making bodies and our integrated care systems, our NHS providers within those integrated care systems are being asked to protect, promote and facilitate that patient voice with respect to services, so that we're not just seeing our patients as a unit, but we're actually seeing our patients as a co-producer of the services that are going to be delivered. So I actually think there's a real opportunity to strengthen our patients' voices at the local system levels. And again, not just as a commentary on the service, but actually as a source of genuine co-production, as a source of genuine knowledge of what they want to have services or how they want the services to be delivered to them.
Do you think, given the sort of history of the past few years with ICSs and their formation, that the mechanisms are there and they're mature enough yet for the patient voice to be truly heard as well as the professional voice in the ICSs, or do you think there's more work for us to do?
I think there's always more work to be done. But as I said, from those early adopters of our integrated care systems, I think what we're able to see is that they really are taking that joined up approach, and they're very population focused. And I think that approach means that, more people will be involved, more patients will be consulted, and I think we'll see more patient-led forums that will be able to strengthen that patient voice in our local systems, so that we can start to adopt more of what our patients want to see and less about what we will want to deliver because it suits us or because it's the way that we've always delivered our services.
Nick, you want to come in there?
Just highlight around bringing sort of the community's voice back into this decision making. Obviously, one of the big changes that diagnostics is undergoing at the moment is the establishment of these community diagnostic hubs in ICSs. So gone will be the days where all patients have to attend for a routine outpatient diagnostic procedure, usually some sort of X-ray, ultrasound, MR or CT scan. Gone will be the days of them having to attend the acute care setting, i.e. a big hospital. Most ICSs will have started, or at least they started to have made these plans for community diagnostic hubs, where the key is, in the word, it's a community diagnostic hub. So these will be based in places where it is easy for patients to access. So, we want them to be easily accessible by public transport, if public transport is available, that patients' voices are heard when it comes to things like parking.
And I'm guessing that these will develop, the community hubs, with the technologies that we've seen implemented with such rapid speed over the past year, that perhaps some of the concerns of the patient about community hubs being a long way from specialists and the specialist centre, that actually we've seen these distances drop with the virtual working that we've had to adopt so quickly, that perhaps that some of those arguments and fears that might persist in the public mind may disappear, and that can only be a good thing. I'm going to put the question to Anna now, but what I'm going to suggest is that we move on to the next topic, which is related, and this is particularly as Anna also has a role as the trustee of IPEM with special portfolio, I think is the word, for EDI. So In terms of the patient voice and taking it that step further, one of the aims of the white paper is to address health inequality for everybody, and it makes this very clear all the way through that this is the case. So taking that patient voice a step further, do you think that the white paper proposals will address health inequality effectively, and what will need to be done to do that?
Well, the first thing I'd say is that, of course, the white paper is very aspirational. It's not even a guideline or a framework, is it? So it's saying this is what we'd like to achieve, and the whole point about creating ICSs is that the onus then is on you guys to find your local solutions, and I like that idea, I really do. But they can't do it on their own. They're going to need a lot of support. So I think people who aren't involved in healthcare assume that it's just because no one's thought of it or we don't want to do it. And of course, it isn't about that. It's more to do with we don't know how to do it and we don't have the infrastructure to do it. So I'm hoping that it will get people thinking differently. I think that primary care and community care don't know how acute care works and vice versa. I know community hospitals often feel like that they're the poor country cousins to the acute teaching hospitals. And they don't even know where to start to have that conversation or to pass that information around. I don't know that they've necessarily got, someone like my mum's voice or my dad, and the complication of someone with comorbidity dealing with an incredibly complex system, and getting lost between different levels and groups and not the right phone numbers. And for me, I feel this was very long way. It fell short of really having a powerful patient voice. And what's interesting about the people I've been speaking to at the Institute of Health Management is that they're also putting together their paper on integrated care systems, and they decided to put the patient's voice right up at front. It's how their report begins, with vignettes from different patients and what they want. And I like that. I like that idea.
Do you think that perhaps as a profession, IPEM and its members have a unique role to play in enabling patient voices to be heard?
I do, in some respect. But I think what I would say is, if we're going to be addressing the specific needs of individual patients, but also the population, we've really got to start to understand, and Anna sort of touched on this, we need to understand exactly what it is that they need and exactly what it is that what are those health inequalities, and the health data, that's one thing, and collecting it is really, really important, and we know that there are barriers to accessing it, and that absolutely needs to be addressed. Anna, you're absolutely right. But what we need to understand is, how do we address those inequalities? But if we're going to address the inequalities, how people don't know what the journey is into healthcare, or they don't know how to access the healthcare that they need, we need to understand things like the local population demographics, what's important to that population demographic. We need to understand what are the local barriers that stops us from achieving that health equality in our populations. And the only way that we're going to do that, and again, Anna alluded to this, is that we need to work jointly with our local populations. And, whatever actions or strategies that we start to develop to overcome them, we need to start to involve, for example, our clinical engineers. If our clinical engineers are part of, that whole cycle of working with that equipment, that really important but scary equipment that our population's accessing, then how do our clinical engineers get involved in demystifying all of that equipment for our patients and the populations, so that they understand what it is that they need and how they access it. So I suppose we need to understand what is it in particular that stops individuals from accessing the healthcare that they need, and how as professionals do we address that. The other thing that we need to do is I think we need to increase that clarity and awareness to our patients of what their rights are actually, because a lot of our patients and a lot of our population don't even realise that they actually have a right to have a say, they have a right to have a choice, and so we need to try and address that. And I think when we do start to look at those areas, and when we can really start to evidence what are those health inequalities, then we can truly start to address them. And I think what the white paper actually doesn't do is it doesn't ensure or put in place a framework or even ask the questions of how we're going to evidence that we've done that. So how are we going to ensure, how are we going to show that we've addressed in every population group, in every geographical area, for every healthcare setting, that we have broken down those barriers to inequalities? And I think as health leaders, I think it's incumbent on us, and it's incumbent on our IPEM leaders to make sure that we are having that positive impact on our local systems, and especially now that we're going to be moving down into those integrated care systems, it's incumbent on us to make sure that we are involved in those conversations. And in being involved in those conversations, we're making people and other leaders in that system think about the people who are not accessing our services, not just the people who are accessing our services. I think that's where our medical physicists and clinical engineers can really start to have an impact on health inequalities.
Thank you, Angela. And that beautifully ties me into what I was going to move on to here, that one of the things that's come out of the pandemic is that pretty much every minority group has suffered more than perhaps the majority. They've had specific outcomes, and that's often the case with healthcare. And I think if I go now to Nick, who's, if we say, more on the front line, do you feel that this greater integration proposed by the white paper will enable you as a service deliverer to address some of the barriers that your patients are encountering when accessing your services to enable greater healthcare equality?
Yeah, COVID-19 has obviously exposed a lot of inequalities in access to healthcare. I think that the white paper's references to the establishment of ICSs having a duty to collaborate, in terms of the bodies within individual ICSs will have a duty to collaborate. Take, for instance, a super well-performing, outstanding CQC rated acute teaching hospital that is in the same ICS as a CQC rated requires improvement DGH or community hospital that provide the same diagnostic services. One may have a very, very short waiting list, one may have an extremely long waiting list. And it goes back to what used to be in tabloid speak, the postcode lottery. You know, if you were fortunate to live in a particular area, that you could access those diagnostic procedures with very little waiting time, great. If you were stuck in the area that was served by a much longer waiting list, then you just had to suck it and see. Now, the fact that trusts and care providers in individual ICSs will have to collaborate may well mean that the waiting lists will move or be shared between organisations. Of course, that does require a lot of IT investment, infrastructure, but it comes back to this sort of levelling up. I sound like a politician, but there will have to be increased cooperation between, for instance, as I said, a DGH and a large teaching hospital that are next door to each other, so that these inequalities can somehow be addressed. I mean, I've not even touched upon the devolved nations. I think that I'll leave that to Robin to talk about Scotland's access to diagnostics. But when it comes to things like PET-CT, for instance, which is commissioned nationally by the specialised commissioners, the white paper talks about this continuing to be held at a national level to ensure that patients have access to services across the country. Whether that happens or not, that relies on investment in more scanners being closer to people, rather than if you're living in a rural community having to drive several hours to access your diagnostics hub, compared to where I am fortunately living in inner London, where I can travel 20 minutes to get access to my diagnostic hub.
Do you think, Robin, that the white paper proposals will help get the funding to where it's needed most to enable us to actually deliver the aspirations within it and counteract the healthcare inequalities? Or do you think that potentially it has the opportunity to hinder this?
I think I'll be honest. I think the proof is in the pudding, and I'm not sure. I like the pleasing pragmatism. Some of the language and honesty of the white paper is quite refreshing. I also like there's certain lines like "led by those who know best." The idea there that would be healthcare leaders. Actually, it's great to hear Nick and some of Nick's perspectives. I think it should be the folks who are delivering the services who need to have a stronger voice in how we address healthcare inequality, and that's often clinical technologists, often who don't have very much of a voice. And we need to sort of integrate them better into our decision-making processes, because those are the very pragmatic folks actually delivering the services. Other than that, I'm really not sure. We talked about the complexity of devolved associations, and I know that for some time in Scotland we've been going in a slightly different direction to the rest of the UK nations, in that we've centralised services. So closing smaller units and bringing large centralised specialised units together with economies of scale, etc., and better transport hubs. So I'm not sure how all this plays out. As I say, I think the proof is in the pudding, and we should hear more from the folks who are delivering the services and from the likes of Anna's mum.
Brilliant, thank you. And I'm going to go to Anna now, because you have a regional role, and your region is one that has areas of deprivation and also areas of wealth. And I'm just wondering whether you feel, at the regional perspective, whether the funding as proposed in the white paper will enable you to ensure, not you personally obviously, but enable the region and the ICS to make sure that the funding is in the right place, and whether the mechanisms outlined within that are robust enough to do so.
So what I would like to be able to see is if the funding can be used for us to be able to break out of what we normally do and have, if you like, almost multidisciplinary community care teams that involve scientists as well as medics, as well as nurses, and the AHPs. They're all needed to help people be able to get what they need much closer to home, and to be easy, because it's scary going into a hospital. So if we can be able to push some of this tech out into the community and into community care homes, and I think that's a good thing. So then maybe that brings us back round to training and education, and maybe putting more of a kind of community/primary care module into some of the training schemes that we have at the moment. So I don't know. I think will there be enough funding? I think it's much to do with how creative we can be in our own regions and ICSs.
Thank you, Anna. And I'm going to come on to workforce and education in a minute, but I'm just going to sort of crystallise that. So for what you're saying is that particularly perhaps the engineering component of our professions have a particular role to play in this. And perhaps I think we can assume that given the amount of money that's been spent nationally and globally on COVID, that belts are going to have to be tightened somewhere in the system. So Angela, with respect to that, do you think we as engineers particularly have a role to play in ensuring that the funding is utilised in an innovative way to make sure that patients get the best care and the best value for money, and that the two are compatible with each other?
I absolutely agree with everything that Anna has said, and in answer to your question, I think every healthcare professional has got a role to play. I think we need to plan the care of our future, not based on what we've done in the past. I think we need to think about, you mentioned the last year and how quickly we've brought innovations into play and for patient benefit. There will never be enough funding. Let's get that straight. Even if we doubled the amount of investment in the NHS, there will never be enough funding. It's almost like a bottomless pit. So what we need to do, and this is for our clinical engineers, medical physicists, as well as any other of our healthcare science professions, we need to think about how we use that money more effectively. So, we generate a lot of data, we talk to our populations, we talk to our healthcare professionals, and we actually have a real potential now to start to generate some significant health benefits so that we can increase that patient independence. A little bit about what Anna was just saying. Think about centralizing where we need to centralize and localize actually where it improves the quality of care for our patients. And I think the higher our patient satisfaction, then actually that's a more efficient use of the funding that we have. What the white paper highlights, I think, is that with our integrated care systems and care partnerships that are going to be used as our sort of local authority partners, I think what we need to be making sure is that our clinical engineers, medical physicists, other healthcare scientists are part of that forum that is going to be agreeing and coordinating any action for alignment of funding, and to make sure that that funding is aligned to address the key issues. We also need to ensure that the funding gets to, as Anna was saying, where it's needed most, and that might not necessarily be in the acute trusts. Actually, that might be in our local care homes. It might be in our hard to reach communities. And I don't mean hard to reach communities in the ethnicity perspective, but in the rural perspective. Why should our patients have to travel 200 miles to be treated, to be seen? I think where the white paper will support some of what we've been discussing is the changes to the tariff that's going to enable that tariff to work more flexibly within local system approaches. So it'll allow decision makers who are perhaps closer to the communities to allocate funding according to local needs and local priorities, rather than to have that funding dictated by national priorities. And I think that's where the real sea change is in what's being proposed in this white paper, is that it's that moving away from the national direction down to more of a let's do what is needed locally. And if we get that right, I think what funding we do have will then be used more efficiently and effectively.
So staying with you, Angela, we've talked about funding being a limiting factor, and one of the things that Anna alluded to was workforce, which arguably is another limiting factor to the aspirations of the white paper, particularly in our professions, and because of its diverse specialist nature is particularly prone to shortages in various areas. So the Secretary of State has to publish a report every 5 years on workforce planning. We have a short-term plan for 2021 for workforce planning. However, we don't have a long-term workforce plan for the NHS, and particularly in our professions, there is an urgent need to work on how we retain and reward those considering coming into our profession to make sure that we can deliver these services. What do you think we as IPEM can do and as professions can do to address this?
So we've been working with the NHS People Board at NHS England on the NHS People Plan. The idea of the NHS People Plan, it's not just a 1 year, it's an ongoing long-term workforce strategy. And I know it isn't specific for this particular workforce, and it isn't specific for our healthcare scientists. But actually what I think we need to do as a healthcare science profession, and in particular what we need our medical physics and clinical engineers to do, is that collaborative working between the Health Education England and the National School, and to start to develop further some of the recommendations that were in that People Plan. And I know that certainly some of our regional leads have been working with our new workforce appointed lead, Jo Nightingale, who's taken a lead on workforce. What we need to start to do is start to show the need for that flexible and future-proofed regional workforce operating model. So we know that different regions have got different workforce needs. You know, we've been looking at the data. We've been working very closely with Health Education England around some of the ESR modelling. But what we have to do is start to address the local workforce planning needs through the data. And, you know, we're starting to develop that now with Health Education England. And what we would like each of our professional groups to do is to take the workforce data that's being generated, that we can look back over the next, we can look back over the last 5 years, but then also model over the next 5 years as well. So we can start to see where do we see those significant gaps, and how do professional groups, professional bodies, our leaders start to engage with that data so that we can start to deliver a real purpose in our workforce strategy. I think it's the data. We really need to understand the data. We need to start modelling forward. And then we need to work very closely with our professional groups, Health Education England and the National School to address the gaps that we see will be looming in the future.
Robin, as the representative on the Professional Standards Council, what do you think, and I'm coming to statutory registration in a moment, but what do you think the barriers to particularly the clinical technologist workforce, where there are significant shortfalls, what do you think the main barriers to actually implementing that are?
I think they're inherently structural, and I'm not sure the white paper really addresses them. Taking it back to the coalface, there's been a chronic shortage of practitioners coming through the practitioner training program. That's evidenced by universities finding that the courses are simply unviable. There's simply not enough folk coming through them. I think we have to ask the question why. And some of that is structural. So take my own discipline. In nuclear medicine, you can become a radiographer and work in nuclear medicine, and you would have the government bursary, the AHP bursary, which would give you support of 5k, for example. But if you do the PTP program, you don't get that level of support. So why would you then? We economically disincentivize becoming a practitioner. Just stick with that same issue. If you were a radiographer, you would get the bursary and come out to get statutory registration. You would be recognised. Your skills would be recognised. Whereas if you do the practitioner training program, you won't. You'll go onto another PSA register. So we have real structural problems that disincentivize becoming a practitioner. And I'm not sure that the white paper really addresses that at all.
Yeah, so this is an inequity, professional inequity, if you like. in funding. Do you think that there's appetite from the clinical technologist community, in particular, where you've given this particular disparity, to work with organisations through IPEM, such as the National School and Health Education England and the CSO's office, to try and perhaps, now that the regional landscape is disappearing and health education is becoming a national organisation, to try to address this?
I would hope. Thanks. I would hope that there is. Certainly, for example, take our own National Technologies Training Scheme. We have been looking at the National Occupational Standards and making sure that what we deliver as clinical technologists is up to date and addresses how the state of the art has moved. I know that IPEM is trying to hold open dialogue with the National School, for example, to see if we can harmonise our curricula. So I'm hoping that some of these moves will help open up discourse, open up dialogue, so we can come to common agreements where actually what we deliver on the coalface is driven forward.
So what I'm hearing there is that there are challenges, but hopefully with a collaborative approach, as recommended by the white paper, we can hopefully address some of these. And the other one I want to move to, because I'm conscious that we're now starting to run out of time, is the point you raised earlier, you and Nick, about statutory registration. And I know that Angela's team have worked with the HCPC on things like patient group directives. We've had new professions gain registration. And whilst the white paper says there are mechanisms for new professions to come on, which they're not taking off, there is a general feel that perhaps the aim is to remove professions. So is it the case that the clinical technologists should be working very hard to gain registration, or should we as scientists be working with them, not only to make sure that they gain registration, but that we don't alternatively potentially lose ours? And should this be a broader healthcare science approach, do you think, or do you think we're right to do it because of the difference in the professions, profession by profession? I'm going to start, I'm afraid, Angela, with you, as perhaps with the most oversight on this.
Absolutely. Yeah, no, absolutely, Robert. And this is something that, we have been discussing in the office of the CSO for some time now. And what I would say, it should be, regulation and registration of professions should be about reviewing and regulating those professions based on risk and need for regulation. It's not about just regulating everybody because everybody should be regulated. It's about the risk and the need. So bearing that in mind, what I think the paper does is it reduces that bureaucracy to regulation, which I actually think we welcome in CSO office, because some of the processes actually create barriers to regulation for those groups that actually do need to be regulated. I also think that if we reduce the number of regulatory bodies, that's actually going to aid public understanding of the sort of wider regulation processes. And I think it will also give our public a greater assurance of who should be and who shouldn't be. And then that provides them with a voice to support where, for example, we think professions should be regulated, but for a safety and risk and need reason, but they're not. That's where public understanding can actually push for those greater assurances. Now, I know the paper says there may be a need to reduce the number of regulated professions, but I actually think there may be a need to increase the number of professions to be regulated, not just to reduce them. And again, I think we need a process that's going to be flexible and responsive, especially to the new developing landscape, because we're developing new agile workforce roles, we're developing different ways of working. So I think it shouldn't be just about reducing those regulated professions. I think it's about reviewing and regulating those professions based on risk and need for regulation. So, and we're more than happy to work with those groups who currently sit on voluntary registers, those groups who are not regulated, to see how we work to get professions regulated that need to be regulated.
And I'm guessing, Nick, that the challenge here, particularly for your group, for whom clinical technologists and practitioner represent a broad range of professions and specialisms, is getting the right level of professional specialism to make the argument effective without diluting other professions and ensuring the right members are regulated. Would you agree with that?
Yeah, absolutely. I think, and also come back to what Robin touched on about it being a structural issue, in that I'm going to say something controversial. Modernising scientific career pathway for clinical technologists seems to be predicated on this natural graduation from being a practitioner to a clinical scientist. Now, what that unfortunately does is it disincentivizes technologists to think of themselves as a profession in their own right, and it means there is nothing in MSc to talk about advanced practice clinical technologists, as opposed to a very clear four career paths for radiographers, for instance, where they go from being kind of assistant, associate practitioner, eventually a consultant practitioner. Now, technologists under the Modernising Scientific Careers pathway, there seems to be this assumption that there will a high achieving and talented and aspirational technologist will want to go into science training. Now, that obviously means that they will no longer be a technologist, so they will actually be taken away from that area of work that they're very good at, and will be missed if they are no longer patient facing. The other thing, I suppose, to talk about is the big push for apprenticeships. We should be encouraging vacancies to be converted into apprenticeships. It's unfortunate that there are very few undergraduate courses for clinical technologist training now. So I think we, as a small workforce, with a smaller voice perhaps than clinical scientists and medical engineers within IPEM, do speak up and engage with educational establishments to say, we have this chronic shortage of trained staff. We need you to facilitate courses so that we can get our workforce of the future trained and ready.
Thank you, Nick. And I would love to discuss this for another 20 minutes or so. And I think we might have found a topic for another discussion, because there's some really interesting points there that I think we probably shouldn't dismiss in a very brief space of time. So at that point, I'm going to into the last topic, which is going to be a quick one-sentence answer. We've talked about innovation. We've talked about workforce. The white paper is all about innovation and riding the momentum of the pandemic. It wants to happen, as it says itself, at pace. Do the panel feel that now is the right term to do this at pace, or we're all too tired and need a rest? I'm going to go around on order of my screen. Nick?
Now is absolutely the right time. There we go. Short answer.
Okay. Robin?
Can we afford not to?
Anna?
Yes.
And Angela?
I think this is a unique moment in time when we need to continue to build on the legacy of COVID. I absolutely agree with everybody. We have to do this now before we have a chance to slip back into old ways of working. So yes, we need to do this.
And I would agree. I think as a profession, we've done amazing things over the past year, and we can continue to do so. I'd like to say thank you now to all our panelists who've given up some significant amount of the time, and without exception, who are extremely busy. So thank you, Angela. Thank you, Anna. Thank you, Robin. Thank you, Nick. And thank you to those of you who've listened for the past hour or so. I hope you found this useful, and I hope you found it interesting. Please like, share, and distribute the podcast in all the social media type ways you can possibly think of, and to the wider IPEM and beyond our profession, actually, because I think this is a really good introduction to the role that we can play. And I also hope as IPEM members, you found something useful in this debate. As I said, it will form part of a series of discussions over the coming months and hopefully years. They will be written up in scope. If you have a topical idea for a debate or would like to suggest that we carry on this debate, particularly with Nick's idea, and pick it up perhaps with a different panel, then, or even put yourself forward to be one of those panel members, then please let the IPEM office know. And someone from the office and from the communications team will be in touch to explore your ideas with you. The next podcast will be announced via the IPEM weekly updates and social media channels, so do keep an eye out. Thank you for watching, and remember, together we are IPEM and we can do brilliant things. Thank you for your time, and thank you again to our panel members. Goodbye.